Thank you, Dr. Mulligan. Good afternoon, everyone, and thank you for coming to this talk. My name is Fred Papali. I'm a pulmonary critical care fellow in Baltimore. And today, I'd actually like to introduce you to several initiatives we've established in Port-au-Prince, Haiti. The new title of the lecture didn't quite make it in time for printing. So these are projects that I'm quite passionate about, and if scaled appropriately, I believe have enormous potential to impact the lives of critically ill patients around the world. So the image that you see here, I think, is quite typical of a low-income country and reminds most people in this room of kind of the things that we think about in relation to global health. Lack of access to healthcare resources, lack of access to potable water, to sanitation. These are underlying problems that contribute to disease in resource-limited countries. And understandably, a lot of funding goes towards trying to eradicate these major problems. But one of the things I've come to realize in my time overseas is that when somebody comes into the hospital, critically ill, barely clinging on to life, what matters most to me is what can I do right now to save that patient? What can I do right now to resuscitate him so that he can go home, or she can go home to continue providing for their families? And when I looked into this, I realized that critical illness is a major problem and a very underappreciated one around the world. 5 million people, estimated, die every year from accidents related to trauma. 19 million people die every year from severe life-threatening infections. Now, a typical ICU patient in a high-income country tends to be older, has multiple end-stage diseases that are less amenable to cure. But in low-income countries, people who are critically ill oftentimes are younger and have a new acute illness that presents in an advanced stage, and that illness is oftentimes amenable to intervention. So why critical care? It almost seems like an oxymoron to talk about critical care in resource-limited countries, because typically we think of ICU medicine as high resource and high cost. Well, the fact is that critical illness happens, right? Every single one of us, you, me, people outside, will all become critically ill at some point in our lives. Critical illness is not limited by language, it's not defined by political boundaries, it happens to us all. And also, critical care does not have to be expensive. The World Health Organization defines a very cost-effective intervention as, let me see if I can get this right, something that costs less than the GDP per capita per disability adjusted life year. And when you look at global health literature on the surgical side, emergency surgery for trauma and for obstetrical complications falls well within these guidelines. And so extrapolating this, critical care actually is very cost effective as defined by the World Health Organization. Also, the core principles of critical care are the same in Southeast Asia and Sub-Saharan Africa as they are in the United States. So cheap and effective interventions can actually be scaled to any geographic locale around the world. We believe we found a winning combination with our work in Haiti, and we'll call this resource-limited critical care. So the essential concept of really any global health intervention is that it has to be effective, it has to work, it has to be simple, and it has to be inexpensive. And these concepts apply to the 3 pillars of resource-limited critical care. The first pillar is education. In other words, training healthcare workers in acute care or critical care best practices. The second pillar is evidence-based medicine. That is developing protocols, data-driven protocols germane to resource-limited countries in order to reduce morbidity and mortality. And the third pillar is technology. In other words, leveraging existing facilities and existing resources and technologies in order to drive down, reduce the cost of care, and to improve the efficiency of the delivery of critical care medicine. We do our work in Port-au-Prince, Haiti, at St. Luke Hospital. St. Luke was founded in the immediate aftermath of the 2010 Haiti earthquake as a field hospital, literally tents in a gravel field. And over the past couple of years, it's developed into a beautiful campus and truly a world-class institution with brick and mortar structures, including this intensive care unit that you see there. St. Luke Hospital has been a pioneer in novel methods of promoting critical care education around the world. This website that you see, this is a screenshot of marylandccproject.org. This is a website that was developed by my colleagues at the University of Maryland. Every Thursday, we live stream several ICU lectures to Haiti and to the Dominican Republic. These lectures are freely available on the website to promote asynchronous learning. And our informatics guys tell us that we've had over 200,000 hits from 164 different countries in the past year. So clearly there's a voracious global appetite for critical care education. Websites are simple and they're effective. St. Luke Hospital has also been at the forefront of global health research. Last year, the physicians at St. Luke's were the first in the world to clinically validate the World Health Organization's protocol for severe sepsis and septic shock in resource-limited countries. Our results are actually going to be published soon, and I'm quite confident they'll make waves in the global health community once they are. Protocols cost nothing. They're very straightforward, and time again, they've been proven effective. Lastly, St. Luke Hospital has also been the site of a pioneering effort to develop an ICU consult service using the existing telemedicine program that we have at the University of Maryland. This program requires mobile technology, and in our case specifically an old iPad that was donated, an internet connection, and clinicians on either end of that internet connection. And so far, the physicians at St. Luke's have been able to call in consults when they felt like they were in over their heads. This has actually boosted their confidence because they know they have a backup, and also this has actually helped to hone their critical care skills. 2 minutes, gotcha, almost done. A natural extension of the tele-ICU program is a tele-ultrasound program that again has helped to boost the confidence of the physicians at St. Luke's. This program has used just mobile phone technology, an internet connection, and has allowed physicians in Port-au-Prince to communicate with physicians in Baltimore in order to discuss difficult cases and difficult images. And this service is available 24 hours a day. And just to drive home the point, this was actually a case in which I was involved. This was a young man who came in with abdominal pain, nausea, vomiting. The ER physician there actually scanned his belly and saw this. We weren't 100% sure. Took a quick picture on my cell phone, sent it to my colleagues at the University of Maryland, and within 5 minutes they said, yes, absolutely, this is an appendicitis. Get that guy open right now. So we referred him for emergency surgery. He lived. It's quite possible that he could have died had the technology not been there. So where do we take this? Obviously, we need more research, right? Our programs have been very successful on the local level, but we want to expand this to the national and hopefully international levels as well. But we can't do that without funding. So far, everything that we've done has come out of pocket. It's been tough on a fellow's salary to go down to Haiti, but I've managed to do it. And with that funding and with that research, then we can expand these programs to hopefully truly impact the lives of critically ill patients around the world. Thank you.